There's a lot of controversy over the development of the airway disturbances or dysfunction that lead to sleep disordered breathing, specifically snoring, obstructive sleep apnea, and URs. And clearly there are a number of aspects to this, or facets to this, and that includes genetics, and then other hereditary factors, familial factors, weight gain, and other lifestyle choices. But from a dentist standpoint, although to a degree some of those can be influenced, from a dentist standpoint, we need, I believe, to look back at the developing child. Children who sit with their lips apart are usually mouth breathers, and they're usually mouth breathers because they need their lips apart to breathe. If they're going to breathe through their mouth, their tongue can't take the optimal position. An optimal position is the tongue filling the mouth oral cavity, and the tip of the tongue being forwards and up. In fact, there's a little area, the incisive papilla, just on the inside of the teeth, in the middle, and that is the point at which the tip of the tongue starts its action for swallow, deglutition. So if we agree that the tongue should fill the oral cavity, what's going to happen with a child who wants to mouth breathe? Well, clearly, if the mouth is full of tongue, air's not going to go through. And so consequently, the tongue has to be carried in a different posture. And that tongue posture is a lowered tongue posture. And a lowered tongue posture means that the tongue has to flatten out and drop, because that way it can leave an airspace above it. Therefore, the kid who's breathing through their mouth with their lips apart, the air can go in over the tongue, and therefore they can mouth breathe. Now, the problem is that when their tongue has taken this new position, it lies over the teeth. It lies over the back teeth especially. And when it lies over the back teeth, it prevents eruption, full eruption of those back teeth. Now, the problem is, as a dentist, I can speak from experience, we look into a patient's mouth, a kiddie's mouth, and we usually and generally see a level teeth of the same height, therefore a level bite. Now, when they're all in this position that's, if you like, too short, we don't notice so much, because we notice the odd things. It's a bit like running upstairs. Yeah, you don't know how high each step is, but if there's one step that's different, you'll trip over it. So if we were to see one tooth that had, and the phrase is over erupted, if we were to see one tooth that had over or under erupted, because if a tooth becomes fixed to the bone, and this does occasionally happen with baby teeth in the child, it won't grow up. And there are other times when you get failure of eruption of the deciduous tooth to the same height as the permanent ones that are erupting alongside. So the bottom line is, we spot those things because we're taught to spot those things, but we're not taught to spot even failure to erupt. And when those teeth are not as high as they should be, you can imagine it as a pillar keeping the ceiling from the floor. If that pillar is the right height, then that ceiling can't drop. If the pillar is this height, then obviously the ceiling can drop. And when the ceiling drops, it decreases the size of the mouth, the volume of the mouth. And then the tongue only has so much space to live. Well, it can't move sideways because the teeth are there. It can't move forwards because the teeth are there. You may get what's called a tongue thrust, and that may change the tooth position, but that can, I think, quite reasonably be seen as an aberrant or not normal attempt to swallow. Of course, the most obvious way for the tongue to move is backwards. And since the back of the tongue is the front of the airway, we're looking at the potential for an airway disturbance right there and then, because the tongue is now moving into the active airway.